Hello, welcome to Health Communication. My name is Dr. Katie Neary Dunleavy, and I am a professor here at Salle University in the Communication Department. And today I have our wonderful guest, Dr. Cami Silk, who is coming to us from Michigan State University, and she's going to be talking about her research, particularly focused on health communication. So thank you for joining me today.
Thanks for having me.
So I just want to actually start with the beginning of your research and everything that you started with. And so if I understand correctly, you had an undergraduate and master's degree at Bloomsburg.
That's correct.
More locally. And then you did take off a little bit of time before you went back to PhD. Is that also correct?
Yes, I worked in nonprofit for several years with the Salvation Army.
Okay.
And it was one of those experiences where I hadn't thought about a nonprofit job.
Mm-hmm.
But really wanted to do something that made a difference.
Okay.
And so I considered the Peace Corps and AmeriCorps, and then the Salvation Army job popped up, and it was a community programs director job, and they basically gave me a building and said, make things happen.
Okay.
So it was program development. So it was senior citizens and childcare and summer camp programs and athletic programs and a little bit of grant writing and doing PR types of things.
Mm-hmm.
So it was really kind of this eclectic opportunity to do lots of things that really interested me. But with the Salvation Army, it's a religious organization, and in order to move forward, I would become part of the clergy, which was probably not my calling.
Okay, I did not realize that.
Yes. So I was looking then for something different, and I had an opportunity to work in brain injury, which was the next thing I did for a couple of years as well. And I was the director of a brain injury rehab, which is what sort of got me thinking about going back to school, because what I found useful in terms of doing group therapies with, and I don't have a counseling background, I have a communication background,
Right.
but we would do these group therapies with our clients, and I would be referring back to communication literature. And I kept thinking I should do something with health and connect these dots with brain injury and communication, and really thought I'd go down that road a bit when I went back for my PhD, but I haven't done too much with brain injury, but it was the impetus for studying health communication.
Health communication specifically, and then talking about some of your grant writing, which I know you're extremely prolific at now, makes a lot of sense as to where you're at. So how did you decide Georgia specifically? Did you, I know your advisor was Dr. Roxanne Parrott, so were you targeting her specifically, or was it just that program?
Dumb luck, really.
Okay.
I mean, I think that one of the advantages of today is your ability to really research programs well. And for so many students who get a lot of great mentorship about graduate schools. And I'd been out for, almost 7 years, and did go back to Bloomsburg and talk to a few people, and then had to sort of send away to get information about different programs.
Okay.
Now this is back in the late 90s, so
Right.
now you just go online and look for this information. But I just, found out who was working where doing health communication, and Georgia was one of those programs. And it was also a place I was willing to go.
Okay.
So I was willing to go to Georgia, which is sort of kind of now naive to think that was a big determinant of where I was willing to live. And I got to Georgia, and honestly, I had no clue what I was getting myself into when it came to a PhD program. I thought a PhD would just give me options. I didn't quite realize that a PhD was a research degree.
Right.
I didn't quite get that I was going to be taking statistics courses. I didn't know. I didn't even know what I was. I got there, everybody's saying, I'm interested in the relationship between this and that. And I'm sitting there like, oh my, who are these people, and how old are they, and how do they know this stuff? And so then I was really intimidated, and I'm like, well, I'm here, I'm gonna maybe connect the dots with brain injury and health communication. And so that was fine, and then they told me that I was gonna take some stats classes, and I said, oh, really? And I'm pretty good at math, so that was okay, but I was an English major, so I hadn't done anything math related in a pretty long time.
Yeah.
So that was a bit intimidating. So my first semester there, I was, to put it lightly, I was a freak show, because I absolutely, stayed in on Friday nights and prepared all my classes and looked through videos, so I had interesting things to share. And then after the first semester, it went fine. I did well, I calmed down, and then somebody told me that the person who does health communication there was actually a pretty big deal. I'm like, oh really? And they're like, yeah, isn't that why you're here? And I'm like, I had no clue.
Right.
So I lucked out. And then 2 years into being at Georgia, my major advisor, Roxanne Parrott, moved to Penn State. and she basically took me with her.
Mm-hmm.
She wrote me into her contract, essentially, and they hired me as a fixed-term faculty member at Penn State a week after I got done coursework at Georgia.
Wow.
So when I was at Penn State, I wrote my dissertation there, I did my comprehensive exams there, and then I actually stayed on an extra year and did a postdoc there as well.
Okay, but your degree is from Georgia,
University
correct?
of Georgia.
Okay,
correct.
and is considered a postdoc from Penn State?
Yep.
Okay, okay.
1 year of it anyway.
1 year, yeah, 1 year of it. So I've done a very minuscule amount with health communication, but it's actually where I thought my research would go. When I was a master's student, I was very interested in people who have acquired disabilities throughout life. And just in the small bit that I've delved into the health communication research, and this might be my own issue, but it just seems very overwhelming, you know, that you could get into this one area of health communication, but then it's related to this next area of health communication, which is related to interpersonal relationships or family relationships. Just seems, it was hard for me to focus. How did you come to this focus with health communication and finding some kind of thread to make your research more programmatic?
Yeah, and sometimes I worry about that, about not being programmatic enough. But I think that I've come to it maybe in a backwards way, because I think there's something opportunistic when you're doing grant-related work. And I think in some ways my career has taken an opportunistic path a bit because, oh, this is where the funding is, and this is where we can get into interesting debates about funding driving research, or shouldn't the research drive the funding, and that's a real conflict for a lot of people. But for me, I can easily say that I've always been interested in message design. So how to design messages in ways that utilize theory, utilize evidence, that are accessible to people, so the health literacy issue, and how can we use them, create them and use them in a campaign context to influence people in a positive way. And I've always kind of had that as an undergirding for the things that I'm interested in, and it seems to be what I bring to the table in most of the projects that I do. And so, and how did I find that? I think you find that in coursework. I mean, I think you say, wow, what's helping me out here? What's lighting my fire? What's interesting to me? And then you get a little bit of opportunity. So the biggest opportunity I had was when I went to Michigan State. I immediately began work on the Breast Cancer and Environment Research Center project, which was absolutely about working with scientists and trying to translate the science into consumable messages for people. And so I had this campaign emphasis. So all these things are sort of reinforcing themselves. But if you take a look at my vita, it's a hodgepodge of topics.
Yeah.
I mean, it's the bioeconomy, it's suicide prevention, it's obesity prevention, it's cancer, it's nutrition, it's infant feeding, all these different topics. And I think that kind of keeps it exciting too.
Right.
Because I'm not like a public health researcher who has done their entire life worked on obesity or just worked on infant feeding. And there's a strength to that too, but it's a different model because what we are experts in is in communication.
Right.
And so to think that I have to be tied to one particular topic feels kind of confining a little bit. But it also, sticking to one topic does help you develop that program of research too.
Right.
So there's an interesting interplay of things that help you kind of come to what is it, how do you define yourself?
One thing that I noticed when I was looking through some of your publications, it wasn't necessarily an emphasis on one particular theory, which you had mentioned, but one concept that comes up in a couple of different theories, the idea of social norms and normative beliefs. And I noticed that over and over again in a lot of your research. And I appreciated that so much because it has to do with the communication that you have with other people and how it relates to health. So first of all, can you just talk a little bit about social norms and normative beliefs and how that relates to health communication or the research that you've done?
Sure. Social norms influence our health behavior. And much of this is not conscious, right? We're not sitting there saying, let me look at what other people are doing, and now let me make a decision about what I'm going to do. That's not really how it works. But we are influenced by the observations that we make. And so probably what the best example of a social norms type of campaign, and this is not something that I've worked on, but I think it best illustrates the approach, is binge drinking on college campuses.
Okay.
So students come to a college campus, many college campuses across the country, and they think that everybody shows up and every weekend is drinking a case of beer. But if you actually survey students, they say, nah, when we go out, we have a few, or we have 4. And the occasional person will say they have, 2 six-packs or something. Right. And so you realize that there's a misperception. There's a misperception about the amount of drinking that's occurring. So you gather the data, and you find out that really when most students drink, they drink 3 or 2.5 or maybe 4, depending. And so you've got the reality and then you have this misperception. And so what we found is that if you correct the misperception with the data taken from that group, and this is a big thing, like we're not talking about other campuses, we're talking about your campus and your peers here. If we correct that misperception, over time we can see a reduction in the negative behavior. And so at MSU, I think they've reduced the amount of drinking by like a beer a night or something, which might not sound significant.
I think it
but
does.
in reality, if you're drinking and driving, it could put you under the limit in terms of what, in terms of moving in the right direction over time too. That's a great trend to be able to demonstrate over time. So you can apply that concept, this idea of misperceptions and correcting a misperception, using different types of norms. There's different types of norms. I don't need to get too much into that. But there's descriptive and injunctive and different types of norms. Using those types of norms to create the messages, put them in prominent places, over time can really, really influence people.
Right. And so you mentioned the binge drinking. You said you hadn't really done as much personally on that. So what are some things that you've done and where you've seen these social norms, the actual versus the perceived norms?
Right. So the one project that I'll mention is a suicide prevention project on campus. We partnered with the counseling center. And we did over a series of several years. We started with focus groups and try to find out what people thought about the counseling center, what they thought about help seeking in general. Now, you might think that there's a lot of stigma associated with mental health mental health help seeking. But in reality, students today are a little less feel less judgmental about it. And if you actually, at least the students on our campus, many of them have already been to a therapist or are on some sort of drug to help them. It's an interesting time because that's probably very different than 20 years ago. So we found a little bit of reduced stigma, but there's still stigma. And whether you're actually going to encourage people to go and whether you think you should go, those are all different things that we have different results for. So we did a campaign to encourage people to seek help and to encourage their friends to seek help. So we corrected misperceptions that most people on campus actually think the counseling center is a good place to go for help. Most people have recommended a friend would go. These are the types of things that we measured, and then we did a campaign on campus, sort of a quasi-experimental design where we used certain dorms to have a certain kind of message, and other dorms having another kind of message, and to see if we changed attitudes about help seeking on campus. And our results indicated that those in the experimental condition did have more positive attitudes toward the counseling center and help seeking. And we actually did a behavioral measure, and this is what excites me the most, is we had the counseling center change their intake form so we could find out what dorm people came from. And we did see an uptick in people from the experimental condition, those who got the social norms messages, in terms of coming to the counseling center.
That's really satisfying to have that kind of
really
truly applied research, which a lot of research in our field may turn into, I would say, applied research, but a lot of times what you see coming out of our field is more just the basic research, so that must be really satisfying.
Yeah, it's nice to have a behavioral outcome because it's hard to get. And in our field, you're right, people stop with attitudes or knowledge gain or intentions to do a behavior, but you don't really get to that behavior point often. And so this was one of those like, yes moments for us.
Yeah. So something else that I noticed in your research, and it wasn't in a whole lot of them, but it was a very big interest to me, was you talked about social comparison. And when I've looked at social comparison in health communication, I've often seen it and also perceived it in more of a negative way. So I guess I'm thinking of things like eating disorders. So if I were to have body dysmorphia or some type of eating disorder, constantly comparing my body to other people, which I see as more of a negative. But then some of the things that I saw that you were writing about was that the social comparison, you could learn norms about healthy behaviors. You could learn more about what are perceived behavioral control. Where can I get more self-efficacy? Where can I get more confidence that I can enact these behaviors and have a good outcome? So can you speak a little bit to that about how our communication and how social comparison can help some of our healthy behaviors?
Right, and I think this goes to Bandura's social learning theory and social cognitive theory too. We're so exposed to so many messages, and that's overwhelming, but it's also makes you feel optimistic because there's lots of opportunities then to show examples of what it means to have healthy behavior, right? And I think as health consumers, we struggle today because science is constantly changing.
Yeah.
It's emerging. Hormone replacement therapy is good. No, now it's bad.
Right.
Try the Atkins diet. No. Try the gluten-free. It's constantly changing. Science changes. Science isn't forever. It's not. So it's a moving target all the time. And so you have to figure out ways to help people feel confident that of whatever that they're going to engage in is going to be worth it. It's going to make a difference, which is the response efficacy piece. And you have to make them feel like confident in themselves that they can perform it. So confidence in themselves to do it, self-efficacy, and confident that it will actually work, response efficacy. And so probably one of the best ways we can do that is through important to others who are around us. And that's often family members, close friends, or significant people who we respect. There's certain message sources that work a lot better than others. There's a reason Magic Johnson was the person talking about HIV. Right. There's a reason that Michael J. Fox was the one who was the spokesperson for Parkinson's. On and on we can go with those types of examples because they influence well. And so when we think about the social comparison piece, I think we look around us and we have these opportunities, and for people we respect, people who are close to us, people that matter in our life. And if we can get to those people and get them on board, so with the breast cancer work, mothers, for instance, are key. We want to try to reduce breast cancer at an early age by doing risk reduction behaviors when little girls are in the womb, as a preterm, to during their pre-adolescence and during adolescence, and so the moms become the mechanism for that, the avenue for it. And then in terms of diet, and that's probably the biggest social comparison thing. I think you brought that up too. We need the obesity epidemic in our country is not. There's not one causal mechanism for it. If you take an ecological approach to it, you've got environmental factors, you have genetic factors, you have cultural factors, and how do you get to that? And how do you can't encompass all that in one. I feel like I'm going off here, but I'm coming back to this social comparison.
I see where you're going.
But we're always looking for these specific role models, and so I can feel good about my ability to do something more nutritious, engage in a physical activity, if I look at somebody around me and they can do it, and I say, oh, they can do it, I can do it too. And I think that's a real positive spin, because a negative spin could be that, oh, you're just sitting around eating French fries and hamburgers, and so that's really okay, which is what a lot of people are attributing the obesity epidemic to, that we're more sedentary, that kids just play with their games and watch a TV and on the computers and not physically active enough. But it is much more than that. It's much more than just the sedentary piece. I think having a McDonald's on every corner in low-income neighborhoods, food deserts, all those things contribute to that problem too. But the social comparison and finding those right role models, I think, is one really smart thing, particularly for young kids, and keeping up with positive role models over time. It's going to make a difference in health behavior.
And so to kind of combine those different ideas, first of all, I really like, again, that you're looking at, in your own research, looking at the people that are close to them. I think it's wonderful that we have different celebrities or different icons who can sort of be the face or the name that gets a message out there about a certain disease. But as you mentioned, it really is about the people who are close to you that's influencing a lot more of the behavior. And so I do very much appreciate that. And so a couple of the different studies that I've read of yours talk about mothers with their daughters talking about the breast cancer, which you mentioned, and then parents with their children with obesity. And there is a little bit of the idea of modeling in there. So so you measure things like how much are the parents having these healthy behaviors themselves? How much are they watching TV? How much are they eating this particular type of food? And I don't know how easy of an answer this is for you, but is it more of the modeling that do you think is influencing the children, so the children seeing their parents engaging in these behaviors, or do you think it is more of the communication, the more of the parents telling the child, we should be eating this type of food, or you should be exercising?
Yeah.
I know that's a kind of a difficult question. I'm not sure how easy that is to answer. But.
Yeah, I mean, and I think depending on your camp with this, you'll have varying answers. So, you know, and I think it's, I mean, I'm of the mind, and this is not going to be an empirical statement,
right.
is that actions speak louder than words,
okay.
right? And so it's the behavior. I mean, I think it's a behavior. So you can tell me all day that I shouldn't be eating a whole bag of Hershey Kisses, and then you proceed to eat a whole bag of Hershey Kisses. What kind of message does that give to a child? So I think that there's, I think the key is marrying the behavior with the messages, right? That's the most powerful, consistent message. That's going to make the biggest difference. And I think that's one of the things that is somewhat disturbing sometimes about some research in health communication is it's not a panacea. Like if we just get that message out there, they know what they need to do. Well, really, then the whole world wouldn't be driving through McDonald's,
right.
and the whole world wouldn't be smoking, and we would all be super healthy, engaging in healthy behaviors all the time if it was really that simple. So to me, it's not just a health education problem. We really have to think about environmental issues. We really have to think about how do we get messages across in this competing media age. Who are the right people to deliver these messages, and is it a complex behavior or a simple behavior? And that's something that's a big deal. Like, let's talk about seatbelts for a second. One of the most successful campaigns ever in our country was the seatbelt campaigns, right? And you know why? It's because it's a simple behavior. Click, and you're done, right? You don't have to like do it. You don't have to exercise for 2 hours. You don't have to weigh food or cut it in certain ways or something, right? Those, and even though maybe that's simple, but it's a complex thing to have to do that all the time, every day. But it becomes a habit, you click it, it's done. And then you have this other piece called enforcement. Campaigns that have an enforcement element to them are often much more successful. Are we going to have an enforcement kind of law about, you can only eat so many French fries and then you're going to get arrested, or get a ticket? And now they're trying stuff like that in New York, right?
Although I think it got recalled, didn't it? I thought it
You're probably right,
got
because
recalled,
there was a big uproar because there's so many different camps in terms of who's responsible here. My advisor used to talk about this idea of naming, blaming, and shaming, which I think is great. It's this idea of like when there's some health problem, we want to put a name to it. Oh, it's obesity. Oh, well, who can we blame for that? Oh, let's blame the fast food restaurants. Let's blame people. Everybody always wants to blame the individual because we don't have to put money into it. If it's the individual's fault, they should just put the fork down and do better, right? And then it's the shaming, like, see, we're going to charge you more on a flight and make you buy 2 seats, or we're going to make fun of you. Or so this naming, blaming, shame work is sort of an interesting way to think about health problems, and it kind of helps us work backwards a little bit in terms of how we're framing and defining what the problem is, who's to blame for it, and what types of things, who's responsible for it. Is it you as an individual, or is it the community? Is it the fast food industry? Is it private industry? Is it the government? The government doesn't want to have to pay anything more than they have to for any kind of campaign. So it's better to be able to blame you as an individual than anybody else.
Yeah, and again, it kind of circles back to that original statement that I had, that health communication, it's so complex. There's so much that's there, and the work is, it seems like you just got to chip away at it, continuously and work on these things. And so in the time that we have left, I was just interested in hearing what you're working on right now, what is really fascinating to you about what you're doing currently.
Yeah, I think the thing, I've never considered myself a technology person, and it's kind of hard to ignore it at this point when it comes to being, doing innovative campaign work. So a bunch of years back, I worked with nursing on developing a curriculum to delay the introduction of solid foods into infant diets. This has everything to do with obesity prevention, because what we find is parents introduce solid foods long before the recommended time of 6 months, or 4 to 6 months is what the Academy of Pediatrics recommends. And if you start introducing solid foods too soon, the baby's not necessarily ready to digest the food. And apparently there's some real connections to that. If you have a fat baby, you're going to have more likely to have a fat child, and you're more likely to be a fat adult. And it's a lot more science to it as well. So what are we trying to do? We're trying to then get mothers to not introduce solid foods too early, and this is particularly a risk factor for people of low SES and young mothers. And so we developed this curriculum. It's actually online. It's the infant feeding series. It's been used now across many states. A lot of public health programs are using it to educate mothers. And so it's online. So we thought, well, what can we do differently with this that is really interesting? And so we worked with a person with sort of an engineering background and developed a platform to do a mobile application for low-income moms. And what they'll do is get a challenge every day. So it's sort of using theories of motivation to challenge them to engage in healthy eating practice, infant feeding practices. And so we have a grant under review that we just submitted a couple weeks ago, a resubmission that was scored very well. There's a whole scoring system with NIH for that. And we hope that we'll get that funded, because then we'll be doing that in the fall.
Oh, that's really exciting. And so when would you find out about the grant?
I think June.
Okay, June.
Yeah.
Okay. All right. And we're pretty much out of time at this point. So I did want to thank you again for sitting down and speaking with me today. And thank you for tuning in to this edition of Health Communication.